hello, everyone. Thank you for joining us for this professional development webinar. My name is Pamela Edgar. I am the Director of Education at Caring Kind. I am here to introduce today's program and to thank you for joining us. We'll get started with Dr. Park, and we're so pleased that she's with us today. And it is my honor to introduce Dr. Isabella Park. Dr. Park is board certified in hospice, palliative medicine, and clinical bioethics with a primary board certification in family medicine. She is the Associate Medical Director, Director of Geriatrics and Palliative Care, and the Chair of Bioethics at Northwell, Long Island Jewish Forest Hills. Dr. Park is the executive sponsor for the hospital's Diversity, Equity, and Inclusion Committee that helps ensure health equity for patients and community, as well as cultivating the diverse workforce engagement. She also oversees transitions of care, readmissions, IDR, and throughput efficiency, and case management and social work. Dr. Park is also the lead for age-friendly care for the hospital, ensuring a comprehensive, equitable, and quality care for older adults. She has obtained 3 successful grants with the Samuels Foundation to enhance geriatric care at Long Island Jewish FHH. She oversees and has created several other clinical and operational programs in the hospital and health system. Dr. Park is active in education of healthcare professionals, including the Zucker School of Medicine and Hofstra School of Nursing, and physician assistants. Dr. Park is the founding chair of Asian Bridgesburg at Northwell Health with over 600 members, which was created to help bridge relationships with Asian communities and Northwell Health, and to be cultural ambassadors within the organization. She implemented a health systems physician language referral guide with over 16 languages to promote language and cultural concordance care for patients, the first of its kind in New York, and helped create physician networking groups based on language and culture. Dr. Park is passionate about culturally competent and equitable care for the most vulnerable populations, especially for the elderly and immigrant populations within the health system and in the community. We are so thrilled to have you here, Dr. Park. Thank you so much for being with us this evening. I'm going to stop sharing and let you share your slides and begin our presentation formally this evening.
Okay, I'm going to try to move the slides over on my laptop. All right, so thank you so much for the wonderful introduction. And again, I am so happy to be here and sharing some thoughts and words and perspective. I am a physician, yes, in Queens and Long Island. Queens in Forest Hills Hospital. I often say in the heart of Queens. And I think for most of us who are in the New York area know that Queens is the world's borough, is what they say. And we'll share a little bit of perspective of what me and my team encounter day by day. So again, the topic is bridging worlds and sharing what palliative care, and if people understand what that is and that term and the type of care that we provide in the hospital setting and also in the offices, especially in the AAPI community for those who are experiencing dementia, either yourself or your loved ones, and sharing that perspective and what it can mean to enhance that type of care. I first encountered Caring Kind, I think about a month or 2 ago, and I shared some perspective on really highlighting some of the medical challenges in dementia patients, delirium mobility, and it brought into conversations about doing another talk, especially something that I wanted to really talk about, which is palliative care. It's my passion. My background, and I'll share with you. I think I'm gonna, yep. So I'm gonna share with you, these are my family. I'm gonna share with you, my background is family medicine, and I went into palliative medicine because during my residency in family medicine, where I really want to take care of the whole family from the time that they're young and to the time that they're older, and taking care of them because I was interested in every part of medicine and their life journey in taking care of their health. But when I encountered palliative medicine, it was so important in this time when healthcare can be so complex and challenging and confusing to patients and families. I really gravitated toward that field and specialty, and I'll go into what palliative medicine is. So I left family medicine in the sense of just doing more office and occasional hospital work to truly try to enhance the care of patients through palliative medicine. I came into Forest Hills Hospital as the associate medical director in a leadership role while overseeing a consult service for geriatrics and palliative, where I can really do more care for our hospital and the community. I also learned about bioethics, which is really important in the field of medicine and to understand the nuances of legal and ethical challenges that often happens. And I'll go into that when I share some patient stories. And my background in ethnically and culturally is I'm a second generation Korean American. My parents immigrated here back in the 70s and set up shop in Jackson Heights, and raised us in Queens. I now live in Long Island, but I still practice and spend most of my time in Queens and really cherish the impact that we are making in the Queens community. All right. So I want to go into why we are talking about dementia or just an aging in itself. We are in an aging revolution, and what that means is that the 65 and older, that's traditionally the sense of older adults in geriatric medicine, is the fastest growing age group. And with that, as you get older, it's the primary risk factor for dementia. And I think some of us already know that. But did you know that it is the fastest growing age group and it's growing tremendously? And I just gave a little bit of metrics. This is Manhattan, Queens, Brooklyn, and even Nassau to say that it is growing very fast. And all the other age groups, especially in the younger age groups below 18, is becoming stagnant and it's not growing. And some age groups are even declining. And that's really important for us to know because with age comes with other comorbidities or other disease processes, chronic illnesses, and dementia is there up top. But why are we talking about dementia in the API communities? And I don't know if you guys, I think you already know, but it is the fastest growing ethnic group. And in New York City, in the 5 boroughs, it's over 1.5 million people. And that's about almost 20% of our residents. And if you have a very fast growing ethnic group and we're getting old, the 65 and older is growing, of course, then the dementia impact is that much higher. And again, it's not just a personal and family impact, it's also societal impact, economically, workforce-wise, and also in the healthcare system too. This creates and highlights some of the cultural and systemic barriers, and I'll share with you how that leads to delayed diagnosis. If you have delayed diagnosis, how are you going to take care and have proper interventions and resources for those patients and family members? So this also requires a need for culturally sensitive care. There are tons of other barriers besides AAPI in the API community, but the main one is language barriers, and we'll go into that later. I just want to cover this part because API covers so many groups. There's over 75 countries represented, hundreds of languages, and many, many ethnic groups. And even the idea of language versus dialect, and I think many of us know that, especially in the Asian communities, it is it is the most linguistically diverse in the realm of dialect and languages. Even just in South Asia, how many Indian languages there are in dialects. There's hundreds. And there's also a fluidity to some of those languages, and it's really hard to find some of those dialects and languages. And even if with the language interpretation and using the telephone for language interpretation, some of those dialects are lost or unknown to the medical interpretation catalog. And there's also that constant evolution too, and intersectionality, meaning that new groups are coming in. We have to redefine what Asian means. And many of us also have identify with multiple cultures and ethnic groups, speak multiple languages. And there's intermarriages, interracial, interethnic marriages. So many of our children and generations are very much blended. Now, this leads to also some not so easy way of taking care of our API community. There's also biases, even for those who are API, and that can hurt us. So we do need to understand what cultural humility is, and we'll go into that in a little bit too. So these are some of the learning objectives, and I hope to accomplish some of them or all of them. The first one is to define what culturally responsive communication is within the context of dementia care, finding potential cultural values and communication styles, and recognizing what those specific challenges could be, and apply some palliative care principles. And then finally, to use those strategies to enhance care, enhance communication, build trust, and provide the person-centered care. In the healthcare world, we say patient-centered care, but I want to make sure that you know that we think of every patient as a person as well. Okay, so how does dementia impact patients? And I think all of us may know this already, but sometimes it can be hidden, and it's really important to explain this to our patients, especially in the API community, in the language, and understand that this can be overlooked. And if it happens so subtly, sometimes they don't see the transition happening. So a lot of times when I speak with patients and family members, I start asking them, hey, have you been noticing this in the past couple of weeks, past couple of months? And I always ask my team and other physicians and nurses too, ask them not just recently look at the pattern and the rate of changes. And be specific sometimes. It's not just memory loss and finding a difficulty with remembering things. So even with simple things as communication, I know sometimes I also find difficulty in finding words and having like it's at the tip of your tongue in a way. And but this happens much more often, and there could be a pattern. And even, understanding some of the languages where they used to be so great with English, even though it's their second or third language, sometimes it's harder and harder for them to remember, and they may even revert back to their native languages. You're also going to notice a pattern of repetitive speech, questioning, asking the same question over and over. Cognition is not just about, like I said, about memory loss. It's also about disorientation. And you may not notice it until much later on, but sometimes when they used to be able to pay the bills on time, there's delayed bill payment. The other very common thing that does happen is behavior and mood. It's not often, but you might not see very explosive or big changes in personality, but sometimes they start becoming more suspicious or a little bit more withdrawn too, or they get easily agitated, or they get restless and they start pacing. The other thing that may happen, which happens often too, is something called sundowning, where they also get very easily restless and agitated, especially around the evening time when the sun is starting to set. And that's why they often call it sundowning, where they don't sleep at night. And they're up all night and they're really tired during the daytime. So it really flips over their sleep cycle. And mobility. A lot of times people think, oh, it's just old age. They're slower with walking and they're having increasing joint pain. Oh, it's just the arthritis. It could be, their cognition and the way that their spatial capability and orientation may affect their mobility in different ways. And remember, and this is what I talked about in my last talk, mobility plays a huge factor in dementia progression. If they're not moving and they're sitting more and they're more withdrawn and not going out and being active, their dementia can progress very quickly. So as I promised, I would love to explain and raise awareness of what palliative medicine is. It's a subspecialty of medicine that is still fairly new compared to other specialties in medicine. It's been maybe around now for almost 2 decades. That's still pretty new in the field of medicine. And I fell in love with it because what it did was focus not just on medical treatment, but really a supportive type of view of supportive management of the patient and the family members of the care. So it's very much more holistic and comprehensive in the care of patients. And again, it's not that we don't look at the medical diagnoses and look at treatment plans, but it's to really look at the quality of life, managing difficult symptoms that any other physician may be comfortable with doing, but when it becomes more complex, and there's compounding other issues, especially emotional, spiritual, we are symptom management experts because we look at what else could be going on. What does that symptom mean for that patient in relationship to what they might be suffering with their medical condition? And the goal is to live as fully as possible, not just necessary as long as possible, but as fully as possible. And we work as a team. There's doctors, nurses, social workers, chaplains, and include the caregivers to really look at the approach to taking care of the patient. It's not just treatment plans, it's a care plan. And we try to provide support for the whole family. Even if there are caregivers or involved in the medical treatment or not, we really do look at the patient as a whole with the family. And this is, again, people often confuse, and I put it there on the drawing on the right side, palliative and hospice. A lot of times palliative care is often confused as hospice care. Palliative medicine or palliative care can be provided with curative treatments at any stage of the serious illness and at any age. They could be young, they could be older, they could be at early stages of their disease process, including cancer, stage 1, stage 2, because they might be having a difficult time, making decisions about continued treatment, different options of treatment, doing surgery, and also symptoms. A lot of times it's not just pain, it's the severe nausea, it's also dizziness, fatigue, appetite loss, depression. All of these symptoms that come with a lot of these disease processes, it's also, perplexes the other physicians. So we all work as a team, and I love interacting and coordinating the care and asking everybody who's taking care of the patient, so that way I can really look at the patient from all angles. And the thing that we also like to do, and I kind of mentioned it before, is to really understand um, and making sure that the patients and families understand what's going on, the options for treatments, and making sure that their values and their wishes are considered so we can match their what matters most to them with the treatment options that are available, so it makes sense for them. And when it is time, when they do have their disease is progressing very advancedly and it is becoming more time limited, we talk about what other resources they can receive. And reminding everybody on this call, I think a lot of us may know it already, but just to remind you, hospice is an insurance benefit. It's a great resources for patients who are eligible for it. And they have a lot of resources that are included in the hospice care program, and that could be provided for patients when it is at that time. So, how do we marry the two? Do we provide palliative care only at the very end? No, like I said, at any stage. And the goal of palliative medicine is to really enhance the quality of life throughout the illness. And I like the slide a lot because it talks about how palliative care can be provided at every stage of the dementia trajectory. And to emphasize, palliative care does not mean that it has to be only provided by a palliative care specialist. We sometimes call that every physician should know primary or rudimentary palliative medicine, and this is how we incorporate it in. So early stages, when people are having some mild cognitive changes and there's relative independence, and we are recognizing it, again, early stage is important, and recognizing an early diagnosis is important. And the palliative focus could be is starting to do advanced care planning, and understanding who would be the healthcare proxy, what other, some decisions that you're starting to think about that would be important, understanding the diagnosis and giving support. And the goal is to maintain function. For middle stage, when it's about moderate, when you're starting to see more confusion or behavior symptoms, and they're starting to need some help with daily activities, and there's some safety issues like, fall risks are happening, or they're having a hard time getting around by themselves. That's around middle stage or moderate dementia. And the focus for palliative would be is trying to manage some of those symptoms, and behavioral health symptoms and pain. Sometimes pain is often there because they do tend to have other medical issues, and providing that caregiver support and letting them know that there are safety precautions and resources out there, and helping them with making some decisions. Now, when it's very advanced, and sometimes a lot of patients that we encounter, their family members are shocked to know that it is very advanced. And a lot of times, and I talked about this on my previous presentation, sometimes that infection or that fall, whether it leads to a fracture or not, and the hospitalization can progress the dementia even faster. All of a sudden, the moderate stage can become very advanced stage very quickly. And they're starting to have much more physical deconditioning, more memory issues or cognitive issues, and they're not as talkative, they're not eating as much, and they're not able to walk around. So they're becoming more chair bound, is what we say, or even bed bound. And that's when palliative care is much more involved, and try to provide support and dignity for the patient, as well as helping the family and the caregivers understand what decisions that they have to make, and what options they have for treatments. It doesn't mean stopping treatment. It's sometimes shifting the focus of what type of treatment would be best for the patient. More symptom management, still continuing some acute illness or infection treatment, but stopping or not doing bigger surgeries or chemotherapy because it might become more detrimental to the patient. And really understanding where the patient can go from there. Is it more services at home? Is it going to a nursing home, going to rehab? So those are some of the things that our team, which is an interdisciplinary team of not just doctors, but nurses and social workers, can really help the family and the patient look at different options. And it's not just a one-time visit or a one-time intervention or interaction with the palliative care team. It's sometimes multiple, and it doesn't have to be, again, that specialist. It's a palliative care focus. But then we have the triple challenge. And we say the triple challenge because having dementia is very hard. And it's very difficult, not only for the patient, for the caregivers. But if you add that complexity and that challenge with language barriers and cultural barriers, oh my goodness. And then when the disease itself becomes very advanced and you need even more palliative care services, it becomes really hard. And that's what we face in the hospitals every day. In the offices, maybe as not as intense, but in the hospital, it's a very acute time in their lives, and they have to make some really tough decisions. And this is when it becomes a triple challenge. not only for the patients and the family members, but for the medical team as well. So these are some of the health disparities that we often see. And like I mentioned before about delayed diagnosis and why that matters. You know, a lot of the cultures out there, and not just in the API community, they try to not downplay it, they overlook it. And it's often not brought up to other family members or to the doctors, and they often end up seeking care later. And it really helps prevent earlier interventions and helping the caregivers take care of the patients. The other big thing that we see is a lot of times these patients are alone and they don't bring it up because they're afraid they're going to lose their autonomy and their home that they've been living in for so long. So they don't want to show that they need help. So they seek care later and there's delayed diagnoses. The other issues that we have is access issues. So, and I'm going to talk about language quite a lot. So language other than English is more than 60% nationally, we speak another language than English. So that limits access to information and services for the patients and the care providers. And of course, when I talk about language and culture concordant care, who do we need it? We need it in our healthcare providers. And even if I don't look like you or speak the same language as a physician for a patient, we need more providers who understand the diverse API cultural beliefs and norms and practices, especially regarding illnesses and end of life, because this is where there's a lot of discord and complexity and anguish and suffering. And with that, that also goes into the way of other accesses is they're not using specialized support services like palliative care and hospice. And it's been shown nationally over and over again that we are, the API community as well, are the lowest utilizers for palliative care and hospice services. So we want to really enhance that and change that. Fortunately, in our hospital, we actually are doing really great in addressing and helping the API community and also the Black and Hispanic community. So, which is something that we're very proud of because we're trying to be as inclusive and equitable as possible and using every opportunity to make sure that we are trying to be culturally responsive and making sure that language is not a barrier. So these impact, all of this impact, let me just move this over, is going to impact who? Our patients and our caregivers. And if our caregivers are stressed out and don't have it, then they're not going to be able to provide the proper care for our patients. And it does, and like I mentioned, there are many who are aging alone and facing dementia alone. And that also goes into more isolation and more neglect on themselves, self-neglect. And that's really, really difficult. And I'll share a patient story later on that reflects that. So what is culturally responsive communication? I'm sure you've heard of the term cultural competence and responsiveness and humility. And again, we can't all be experts in every single culture and ethnic group out there. I can't. I'm trying to learn as much as I can. I'm learning every day and I'm constantly surprised. It's like, oh, I didn't know that about that culture or that ethnic group. Oh, I didn't know that. That's a very interesting language. I didn't know there was such a dialect or a language that way it existed. But cultural humility is constantly looking at wow, because I have my own, realize that you have to realize I have my own bias and I do have stereotypes as well. And we often do group people. That way, for example, the Korean community, we're also very respectful of healthcare providers and doctors. And we often say yes, and whatever the doctor says, we do. But that's not true all the time. And, we make generalized statements like that. And I'm surprised over and over again that it's not true, not most of the time, but some of the time. So I think we need to check our own biases and always try to, have that on the back of your mind, but also be open and ask the right questions. So when we talk about competence, it has to go hand in hand with humility and responsiveness. And the focus is on the patient and the family within the cultural context, but always be open to try to continue on understanding. So in the in in the API community, and this is often something that we see in other cultures as well, the family structure and the dynamics is something we have to consider. And we face this all the time in Forest Hills Hospital. The idea of filial piety is also very much evident, and we have to be respectful of that and understand it. And I think people know that there is this idea of collectivism versus pure autonomy and the respect for elders, and how we have this obligation of not by choice, but duty to our elders, our parents. Um, and understand that the family dynamic, sometimes it is going to be the oldest child or maybe the oldest son. So that burden that child has to bear is a lot. We often have patients also who have family members that are abroad, out of the state, out of the country. We have to make calls to India, to France, to China, to Mexico, to get those family members involved and tell them we don't have much time, or we have to make this really important decision. And there's a whole slew of family members that we have to all consult with. So sometimes there's many phone calls and trying to make sure that all the family feels included, but we do need to make some decisions. And so it's wonderful that when patients have family members, that means that there's a lot of advocates, which is great. But understand that it is difficult, and the medical community has to understand and be respectful of that. Now, communication styles, I have a graph up there that a lot of times, especially in other cultures, the nonverbal communication is so important. And especially in the Asian community, when there is respect for for the elderly, for the elders, not just elderly, for elders, the nonverbal cues is just as important as the verbal communication, the words that we use, the way that we use them, the intonations, the tone of the voice, the way that you bow your head out of respect or look at them directly in the face. The communication is very much we have to be aware of. And I'll give you an example of my mother. I can't give examples of other people. I'll give examples of my parents. My mother has been in the US for almost 50 years now. She speaks pretty good English, but she feels still very shy, and she's very respectful of the medical community. So in the doctor's appointment, she can go by herself. She doesn't need also an interpreter too, but she would always be very polite to the doctor and say, yes, yes, yes. And then later on, because a lot of times she ends up seeing colleagues of mine, friends of mine, and they text me and says, "Oh, the visit went really well, and your mom was great. She understood everything." And then she comes home, and I ask her, "How did it go?" It's like, "Oh, I didn't understand what they were saying." It's like, "Why didn't you speak up?" "Oh, I didn't want to be impolite." And it'd be infuriating to me, and said, if you don't understand something, say that you would use an interpreter. She's like, no, no, she didn't want to embarrass herself by using an interpreter, and she didn't want to bother me to have me on the phone on speaker to explain. So then I have to then rehash the whole visit with my colleague who saw my mother and then explain it back to her. What would have been helpful is if my colleague did teach back. So there's other styles, and we'll go into later, and to help, because that's something to be mindful of. Sometimes patients would just nod their head and be polite, and not communicate that they don't understand. So it's really important to know that respect, signs of respect, is much more important to them than knowing that they understand or not understand.
Dr.
There's
Park,
also,
I just want to let you know very quickly that we lost your camera.
oh,
Yeah. So we're not seeing you. We're still seeing your presentation, but the camera went off.
oh, is that better?
You are back. Thank you so much.
Okay, no worries. Thank you. Um, there's also the stigma, like I mentioned before, and there is significant stigma still, not just, obviously with still with behavioral health, but also with cognitive decline and dementia in itself. Because saying that you have dementia, it's almost like saying the word cancer. It's like a shocking revelation for the whole family and in the community. Oh no. And so they want to delay that acknowledgement as long as possible in some families or ethnic groups. So just be mindful and to help reduce some of and mitigate some of that stigma, because so that way they can get the support that they need. So I think we have to be very sensitive to it and understand that as well. The other thing, like I said about decision making, they do focus on family centered. It's really important to involve the family members early. The earlier, the better. So that way you could do education. So even if the patients have early dementia, and it seems like they're with it and they want to maintain their autonomy as and their dignity as much as possible, try to include the family members early on. So that way it's not such a surprise. Um, and, even if you do have family members, sometimes they don't want to reveal the news to their family members, especially about terminal conditions or prognosis and or difficult news. So sometimes you do want to be respectful and still give the patients the opportunity to also express themselves. A lot of times it says, "Oh, we don't need to tell our mother," even though she's able to communicate. "Oh, we don't need to tell her. It's okay. We'll know and we'll make the decisions." And a lot of the Western community here, which is the U.S. community, the medical team have a very strong feeling about that, especially our residents and our medical students and residents, they feel very strong. It's like we have to tell our patient it's their right. So let's be sensitive. Let's see how we can mitigate some of that by saying asking the family, look, I think the patient may already know. Your mom may already know that she has very advanced cancer, or she's not doing well, or this disease is really very advanced. How about we do it together? I'll be very gentle and I'll be there with you when we share some of the information. And we can even ask her, does she want to know? Does she want to know what's going on, what treatments that we're doing? So that way the medical team also feels that we're giving the patient an opportunity to voice their opinion and ask questions too. We don't want to exclude them. So there's a way to balance some of that so that way we are still including the patient. And it's important for a lot of the physicians too. They feel like they need to include the patient. And that's one way to do that without making the family think that we're hurting the patient or making the patient suffer with this terrible news. The beliefs also about illness and suffering is different in different ethnic groups, and it could be based on religion too. Sometimes people in who also believe, one faith versus another, and combined with their culture, um, can view illnesses differently. This is what I have seen in other cultures as well. And I used to do my residency program in Jamaica Hospital, and we had a lot of Haitian and Guyanese patients, and they viewed illnesses very differently than other groups. So it's really important to know how they understand illnesses and treatment options, and ask about other methods of medicine, like complementary and traditional, and try to have an understanding of what they think instead of just talking about, hey, this is how it is, this is what it is, you have to do this. Ask them, what they understand about it and what other questions they may have about their illness. Same thing, especially about end of life views. Oh, it also mixed with their religion and also their culture and ethnic groups. They have very different views on end of life and dying. And I've had a patient that says, oh, Muslims do not believe in hospice, and we do not believe in DNR. We do not believe in this. And it's not so much as the religion as it's the culture. And sometimes they may not understand what it really means. So we have to be really mindful to see where they're coming from and then meet them at least halfway. So that way we can help them understand and we understand what they believe and meet somewhere in the middle. I did not know this, but I was listing all the religions that and I was discussing this with my team of all the different religions that's out there. Obviously, there's the very common Confucius, Buddhist, Christian, Catholic, Protestant religions. There's the Muslim religion as well, and there's also Asian Jewish. There's Asians who practice Judaism too. So it's really important that we ask what matters to them in the role and what role religion plays in their decision making. So how do you impart palliative medicine approach? And I've already kind of explained it. We really looked at, patients from all angles. I am not just a physician clinician who just diagnoses and does intervention. I want to really understand the patient as a person and look at what is also impacting their life. And when they do have symptoms, sometimes it's not so much as the physical things that's causing the pain. It could be emotional, it could be social, it could be spiritual. And so it's really important to ask those questions in all of those areas of their life because the culture also shapes the experience and the expression of those symptoms. Pain could be differently expressed and experienced, anxiety and depression in itself. And again, there's stigma around behavioral health symptoms. So it's really important to understand that. And what I mean is, I ask, especially about pain and in different languages. And it's very different. And, pain in itself, and if you translate it in different languages, it means something slightly different. So I have to be creative in asking about pain in different ways. So for example, instead of saying, where's your pain or what's your pain scale and things like that. And sometimes some patients say, no, 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 I don't have any pain. But when I ask, does it hurt anywhere? Where does it bother you? Are you uncomfortable? They will answer. And then I would get to understand why they're not moving as much because they're uncomfortable or they're having discomfort. So it's very interesting because again, some of the languages, when you translate it, some of the terms, the medical terms, or the symptom assessment that we do in the medical world, it can translate differently. And some people are going to say yes or no, depending on how you ask those questions. We often want to use open-ended questions. What that means is instead of a yes or no type of questions, we want to do open-ended questions and see what they say. It is a bit harder to do in dementia patients, but for family members, it's really important. So that way, it's not just a yes or no. You really want to get to know them. And if you want to build trust, open-ended questions is an excellent way to do so. And it should be the way to help understand your patients better. Such as, what does quality of life mean to you and your family right now? Or what are you most concerned about or worried about? And who helps take care of you? Who's important in your life that makes decisions? Okay, I'm sorry, I'm with my, hold on one second. Okay, so I'm gonna go back. All of these questions that we do, I'm really sorry. All of these questions that we do, we will try to align it with the treatment plans. I am so sorry, hold on one second. I have a dog that's in my family too. And while we are asking these questions, I have told you about using interpreters, and some of those interpreters are often done on the phone. But medical interpreters are specially trained for medical terminologies and health literacy, which is great. We try to use the medical interpreters as much as we can, but we do ask family members, and it's best not to use family. We ask the patients and family members. It's best not to use other family members because they're not gonna. We don't know or can attest to the integrity of the interpretation. And many of our patients, especially Asians, they don't prefer phone interpretation. They prefer live interpretation, obviously, for many of the reasons I had explained before, a lot of the nonverbal cues. I just did an interview today with a Japanese American physician. He is comfortable in English, but still more comfortable, obviously, in his native language. And we did a Zoom interview with a reporter, and her camera wasn't working, so he couldn't see her face. I could see him. So our cameras, I could see him and he could see me. So we saw each other, and I was helping him as another colleague to help with the interview. And it was very difficult for him to answer some of the questions because he said I couldn't see her face to really follow along with some of the questions. So it just highlights the importance of having the facial expressions to help with some of the communication. So in our health system in Northwell, we use something called a video remote interpreter. So just like in the picture there, it's an iPad that has live interpreter services, and they also have American Sign Language as well. So it's wonderful. So they have a catalog of hundreds of languages. Obviously, the more esoteric or the dialects, they might not be as available for live interpretation, but they definitely have a lot more options for just regular audio. But again, when we first rolled it out in the health system about 7, 8 years ago, this is maybe 2 years before COVID started, it was a slow uptick, but we had a really great experiment done in our hospital, ER. Our ER physicians are very diverse too. They speak different languages, but we have a very large Russian-speaking population in Forest Hills Hospital. And they realized this is before we had the video remote interpreter. We only had one or two, and it wasn't easily accessible. So our ED physicians were taking a longer time with the patients that spoke other languages, especially Russian, because it takes a long time on the phone. So they would deprioritize seeing them. They all saw them in a timely fashion, but they were saving them for last to give more time to speak with them because they knew that it was going to take a little bit more time, and they wanted to have a very thorough examination and interview with the patient. So, and it made the ED doctors feel bad, and also made the patients wait a little bit longer. It's about 10, 15 minutes longer, but they saw a difference in that, with those type of patients. So we added a lot more and bought more of these VRI iPads to help with the video interpretation. And oh my goodness, it made such a difference. The interactions with patients and the doctor were so much smoother, faster. The patients were happier, the physicians were happier, and it was a really great experiment. So we rolled out the VRIs throughout the health system. There's plenty so that no one is waiting around for these VRIs. We incorporated into our inpatient floors on the hospitals, in the pre-surgical testing, in the imaging centers, in the offices, in the practices. So it was a huge hit, and it really helped enhance the interactions and the communication with our patients and our providers. And again, it's a great alternative because we can't always have a live in-person interpreter. And it was great for also our ASL patients, the ones who are deaf and needed American Sign Language. You're able to also see the visual cues as well. So, and there's been studies to show that video interpretation has been a better alternative than phone interpretation. So when you are dealing with interpreters too, and I think some of you may have already experienced this when you interact with patients and their family members, please prep the interpreters. I always try to do this beforehand. Brief them of the circumstance and the context. I do not speak to the interpreter or look at the screen, only once in a while just to check if the interpreter is getting the message too. I speak directly to the patient and I wait for the interpreter to translate, but I'm always speaking directly to the patient. And I check for understanding with the interpreter. And sometimes I want to make sure that he or she understands so that way I can move on with the next point and also interaction with the patient. These are some practical tips. And again, I think this is just, basic communication tips 101, but it's even more so when you're dealing with language barriers or different cultures. Again, humility in practice. And again, acknowledging my own bias. And this happens often with my team and with myself. And always be open, help me understand. What did you mean by that? Why, how is that important to you so that I can help you? And active listening and always understanding the nonverbal cues. And if there are appearing to express or exhibit some type of emotion, try to validate it or explore it. And that's the empathy part. But always understand that in a lot of the cultures here in the Asian community, there is respect for elders. So showing that respect for the family structure and the elders will go a long way. And it takes time and effort to build that relationship and trust. And a lot of these patient populations, and we see this a lot in other minority groups. They've been, dealing with a lot of microaggressions all of their lives. So it's really important that we make tight time and effort to give that respect and space for them to express themselves. And again, I cannot say this enough. We have to involve family members and acknowledge that they are going through a hard time as well. And a lot of times my team members, what they say, oh my goodness, this must have been so hard for you, or you're doing such a great job. You took such great care of her. Let us help you too, and we will find support for you. That goes such a long way for them. Because a lot of times when they come in, they're in distress, they need respite care. And a lot of times the medical team's like, oh my goodness, look at all these pressure wounds, the patient's unkempt, or they're screaming, yelling. And then we say, well, how did this happen? Why, the caregivers are going to feel so overwhelmed, embarrassed, or defensive, and they will shut down. So I think it's really important to be empathetic in what they have been going through. And sometimes when they do come into the hospital, not sometimes, most of the time when they come into the hospital, they're desperate. They need help. So we have to be mindful of that. I said this before, religion and spiritual beliefs may be very important to them. So it's important that we ask about it and even connect with some of their religious leaders. I sometimes joke around, but it is true. I have several rabbis that I have phone numbers on because it's important to the community, particularly in the Forest Hills community, that we stay connected with them. If I need help, I reach out to them. If they need help, they can reach out to me anytime during the day and even at nighttime. Because it's important that they know that they can trust the hospital and the medical team, that we respect them and we understand that this is important in their culture. And again, you know, when we talk about dementia, I kind of talked about some of the areas of how it impacts. These are some of the things that are really hard for them, and what are some tools that we can help them to help address it? Repetition and memory loss, using simple questions. And I know I said about open-ended questions, sometimes for the dementia patients, it's hard for them to answer open-ended questions. So read and understand it well. Once you assess that they're having some cognitive issues, use slower tones, sometimes written cues, be calm and reassuring, and ask sometimes simple questions, even yes or no, close-ended questions. So that's easier for them to answer, and they feel also dignified. If you ask them complicated, open-ended questions, it's going to be harder for them to answer, and they become embarrassed. So I try to smile a lot and be very reassuring so they don't feel confused and and find it more difficult to speak. And validate the feelings too. Oh, this is It's okay. You don't have to answer that question. I have another question for you. And if it's easier for them to answer, they actually like it and they smile and they feel more relaxed. And it could actually help with the next question that you may be answering. So I always start off very easy, nice, feel-good questions, and then help them relax a little bit so I can actually have a better conversation and more questions that I can try to assess some of their symptoms and how they're feeling. For mobility and toileting, one of the most common reasons why caregivers often bring them to the hospital or even have to make the difficult choice of bringing to the nursing home is the toileting and mobility issues. All the other issues, behavior, memory issues, or infections, that's okay. They may be able to deal with it, but it's the toileting and mobility that is a huge burden on the caregivers. And so safety in the home and that safety assessment is really important so they don't fall. Falling, having hip fractures or any type of fractures really sets them on the path for faster progression to dementia and more disability and immobility. So it's really important to try to prevent falls as much as we can and helping the wandering and using mobility aids. Toileting is really difficult. So a lot of times you have to see some of the nonverbal cues that they may exhibit. If they start fidgeting and getting more agitated, maybe they need to go to the bathroom. Maybe they're having constipation issues. Easier or more adapted clothes for them to wear. So it's easier for them to, or you as a caregiver to remove the clothes and then change their clothing. And using time toileting is also really important. So they are used to a pattern so that you don't wait for them to signal to you, you try to time it. The behavioral changes. Um, the psychosis is actually more common than not. There's more and more studies out there, and we see it all the time in the hospital. My team members see it often, and family members get really shocked and surprised. But delirium is more common, and psychosis is more common than is recognized. And it's sometimes things that we haven't been able to address. It could be triggered by a lot of different things. Pain is one of the more common reasons. It's fear, foreign people, people they haven't seen before. They become more paranoid and suspicious. And again, sometimes it could be cultural. If it's a different language, they may become more upset and scared and anxious. So it's important that we try to address and know that the doctors really don't want to give medications for these very big behaviors. So we try to find other ways, non-medical ways to help address some of these behaviors, especially the paranoia and the delirium. And know that the caregivers being transparent and up to date and letting them know what's going on is really, really important so that they can be more prepared. I think the biggest help for them is to understand the disease process so they can be prepared. It's overwhelming as it is, but unexpected changes and things that they didn't anticipate, especially symptoms, can be very overwhelming, and that's where they get into trouble. And that's how we can be helpful for them. Oh, and when we are providing resources, especially for the community, it's really helpful if they do have aides and staff that speak the language, especially in the home setting. So finding those aides and nurses that speak the same language to help communicate and see those patients in the home, it's difficult. So we really need to increase or find diverse staffing or organizations that does have those staff that they can help with. So we talk about caregiver burden, and I think some of you may already anticipate this is not surprising to see. Looking at just the cost and the burden of care for patients as the dementia severity increases. So this is not new, and this is expected. But looking at the potential costs, and that includes everything from medical support, loss of work, all the resources that are needed to help take care of the patients as they are their dementia, and their all the other medical conditions that comes with it, that they need care for. And speaking of ADRD is Alzheimer's disease-related dementia. Um, by 2040, look at all the increased burden that is happening for these patients on groups or minority groups that are already facing disparities. And again, the one on the upper top is the API data on language proficiency. So you can see how the Asian community is very much affected compared to other minority groups. And again, the caregiver burden is multifaceted, and I think it's important as physicians, and this is something that I, talk to my team about and our medical team as well, the hospital, knowing that the caregiver burden is multifactorial, and we're so quick to blame, like, why didn't you, bring your mother to the hospital faster or sooner? Why didn't you do this? Why didn't you do that? It's a lot. It's a lot for them to deal with, especially if they are trying to make a living themselves. A lot of the family homes right now are two income families. So having to take care of their children and their elderly parents, it's a lot on them. And many of our community members are in the sandwich generation. I don't know if you heard that before, but when they're taking care of their children and also their aging parents as well. And it's difficult for them to balance that. And especially if they have behavior issues and, like I said, mobility and toileting, it's hard. And a lot of times what my palliative care team faces is, well, who's going to take care of them when they're away at work? They can only be there in the evening, but who's going to take care of them during the day? Um, and again, so sometimes they do miss work. So there's unpaid care for these caregivers. And like I said, we're in the aging revolution now, and we have to be very concerned about who's taking care of our aging population. So how do we support the caregivers? There's, first of all, recognizing that they do have issues, and especially in the AAPI community, there is a lot of pressure that we put on ourselves because they took care of us. We have to take care of them, and it's part of our culture to always take care of our elders. And it's important to understand that and understand the conflict and the guilt that they will always feel. And it's hard because the insurance companies sometimes do not give that respite care, and having to navigate some of that and the insurances is really difficult. So what we can do in the palliative care, field, and the expert teas that we can provide is really recognizing that and supporting the caregivers as well, and making sure that the medical team and the case manager and social workers are really looking at it from that angle and give perspective. So that way we can provide all the resources that we can by addressing the physical, the symptom needs. And that way the caregivers know that there is some ways to help take care of them. So the medical interventions, because a lot of times the medical team may not even address the dementia issues or the delirium because they're so fixated on treating the acute illness, such as like the infection or the hip fracture. They don't address all the other aspects of the patient's care. A lot of times the family conflicts are very real. Sometimes it really impacts the decision making and delayed decision making. A lot, sometimes I think my team feels like we end up being family counselors. It's like, please, you have to stop fighting so we can make decisions on your mom. It doesn't matter the fighting that they had before. We really need to make a decision. You have to come together. And sometimes we have to make phone calls to different family members and say the same thing because they refuse to speak to each other. So it's very interesting in the field of when patients come into the hospital, we see all sorts of family dynamics. There's partners, there's stepmothers, there's ex-wives, there's stepchildren, there's cousins or family members, and even aides that have been taking care of them. So the patients made them the healthcare proxy and the family feels left out. So there's dynamics and ethical scenarios like that are sometimes complicate some of the medical care of the patient. Um, when I talk about caregivers, and I mentioned before, there's a lot of aging patients who are living alone, and family members are estranged and they're overseas, and it's difficult. How do you help take care of them? Um, and so there's legal challenges in that way when they start losing capacity, and what that means that they're not able to make decisions. So who's going to help make the decisions for these patients who are all alone? And some of the terms that they use is isolated seniors and also elder orphans. How sad is that? I know when I heard that term, I was like, oh, that's so sad. But there's nobody else left to take care of them. And also another forgotten group, and I mentioned this before, these are very vulnerable patients. The aging behavioral health, the ones who have psychiatric illnesses, schizophrenia, bipolar patients who are aging. And the OPWDD patients, I don't know if you know what that means. It's often Office of Persons with Developmental Disabilities. So these are development disabled patients that are living longer now, and pretty much with this, they're living the same, the average longevity for these patients are now up to the same as other groups. And that's something that is very complex because some of the decisions, the end of life decisions, do have some red tape. And so there's some legal, ethical navigation that you have to do for those patients. And it does give a more complexity to the caregivers who are taking care of them. But yes, it's very difficult for these groups. And I think we have to recognize that and give support to the caregivers in that area. So these are some of the patient stories I would love to share. These are all real cases, and these are not real pictures. I found this on Google. But it helps to highlight some, enhance the story. So the first patient story was a male patient, Chinese background, and with advanced dementia. Not too terribly. He was able to speak and advocate for himself in some ways and saying, like, I'm in pain, I'm hungry, and things like that. But he was pretty much mostly bedbound. But his main issue was not so much as the dementia as the cancer that was very progressive, and there was no options for chemo anymore. Very end stage. He was having more complications. Now, the brother who lived with him was a primary caregiver. The two daughters that were involved, deferred pretty much. They made some decisions, but they deferred their uncle to be the primary giver and to partake in some of the decision making. They did agree that, yes, we're not going to do any more chemo. It's not recommended anymore. He's not responding, and it's going to cause more harm than good. They understood that. But when we recommended, I think it's time for hospice services, they initially said yes, but the brother, when he realized that people were going to come into the house and try to help him, he refused. Not that he didn't want, hospice in general. He felt that he could take care of his brother. He was very proud and happy to take care of his brother. He took care of him for most of his life because he was the older brother. So he refused to care. He did not feel that he needed it. And he kept saying, no, 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 to the point where we thought, oh no, this is actually getting bad because the patient was getting a little bit sicker. And we even called APS on him because we were concerned about the safety and the medical care or the regular care that he was providing because it was beyond what he was capable of. So eventually he did agree, but in the beginning it took a lot, several actually hospital visits for him to finally agree to get care. But in the beginning, he really refused care, and that we see that often. My own sister-in-law, whose mother had ALS, end-stage ALS, her father also refused services and would kick the aides out because he felt that it was not embarrassing, but he felt that he would not be doing his duty if he accepted help because he was going to take care of his wife. Which was interesting. And it was a big struggle for my sister-in-law and her brother. We had another patient, Chinese as well, with moderate dementia, it's not too bad, but had very end-stage liver disease. Would have issues with fluid filling up in her belly because of the liver disease, and also her blood levels would go very low, so she would need transfusions. Her kidneys were also being affected, but dialysis was considered, but then was put off the table. Now, the patient herself was still had full capacity, was able to direct care, and she made her wishes very well known. And the daughter struggled. She knew, um, all her life she was trying to always honor her mother's wishes because the mother was very headstrong. And the daughter struggled with making any decisions without her mother. So she was always trying to honor her wishes as much as she could, and she did to the end. Very difficult patient in the sense of some of the interventions that she had wanted and what wasn't recommended. She would often ask for interventions that was not medically recommended. And when we asked the daughter to help, she said, no, it's whatever my mom wants. I have to honor her wishes. So we see that sometimes, and sometimes it's the opposite. But this time she was very much until the mother was not able to make decisions, was too lethargic, and her disease process progressed even more. She did not want to intervene with her mother's decision making and wanted to give her as much autonomy, and she wanted to fulfill her duties as a daughter, which the medical team struggled with, but we did also respect it as well. And she really appreciated that. And I think the patient also was at peace with that too. Um, we had another patient, actually, this patient, the picture looked very much like, and that's why I picked it, very much like the patient that was the actual patient. She was an adorable Filipino patient lady, and she had very much end stage, very advanced dementia, had a new stroke, but she was a very voracious eater, but a tiny little Filipino lady, but she just refused to eat. And even though she passed the swallow evaluation, she could swallow, but she just refused all of the food that was given to her. The applesauce, the soup, or anything that the hospital was trying to feed her or give her, she would refuse and she didn't want a feeding tube, and which would not have been a good idea anyway, but and she also refused and the family refused. So we're like, what are we gonna do? And we were going to discharge her home, maybe even with hospice until we said, you know what, why don't you bring food that from home that she would like, anything she would enjoy. She can have whatever she wants. Brought her food and she was gulping it up. And it was fantastic. And knowing that a lot of times, especially the API community, home cooked meals or from cultural foods that are important to them that they like is going to be the best for them. And my mom would say the same thing. When she goes out vacationing anywhere all over the world, she immediately within a day misses Korean food. So she would pack some things that she would eat when she's traveling. Because it's important to them. And sometimes people really do not like some of the hospital foods. Either it's too sugary, too salty, or it's not the same, and the flavoring is off. So we always invite, because we have such a diverse patient population, we always invite them to bring food from home. There was another this is another Filipino story, patient with Parkinson's with dementia, which the family did not know about. This was actually a story that one of our staff members shared, because I was asking people, hey, give me a story about any loved ones or family members or patients who had dementia. And she shared with me, this was her father, her in-laws. It was the in-laws, the husband and wife. They looked after each other, lived together for a long time, been together without the kids for a long time by themselves. And she had balancing issues, and they attributed to her knees. So she had both knees surgery done, but still had balance issues, and she kept falling, and something wasn't right. And the husband did not tell the family, the children, any of her issues, just that she had balance issues, and wouldn't say anything about her cognitive, her memory issues, and that she was struggling even after the knee surgery. And this delay in dementia and Parkinson's led her to have worsening Parkinson's syndrome. So when they found out and finally formally diagnosed with some of the right medication, it really helped her. But he felt like, well, this is my burden to bear. Whatever happens to her, I'm going to have to deal with it. So, and he attributed to karma, even though they were practicing Catholics. Uh, he attributed that this is part of his life and his burden to bear. But the family insisted on more formal evaluation, so that's why they were fortunate enough to diagnose her with Parkinson's and got the right treatment. Another very interesting, another couple also living by themselves was a patient, a Japanese couple. And all of these patients, by the way, they didn't speak English well. All of them, we always tried to use an interpreter for all of them. And this one in particular, the last story. Again, this is not their real picture, but they actually looked like them. So I was very surprised. So I immediately used this picture. The husband had very advanced dementia and ended up even on a ventilator and had a feeding tube. And had a tracheostomy, had to go to a nursing home. And she kept insisting that he can make his own decision. And she kept refusing to make decisions for him. And she said, you have to speak with him. Meanwhile, this patient was nonverbal, could not speak at all. His dementia was so bad. And unfortunately, they have no children, no family at all. And it was very difficult for trying to converse and talk with the wife who kept insisting that he was communicating. So a way to help navigate some of that, we had to go through the legal right and had to go through a guardianship process. So again, the ethical challenge and legal challenges. And the patient herself had moderate dementia, it seemed, later on. And we had to go through the whole process with legal, and because the patient couldn't go back home, it was not safe. And she insisted on him going home. So this was a very big struggle. He was in our hospital for a long time because of the legal issues that we had to deal with. And eventually he went to a nursing home facility. He came back again and he had worsening conditions and he did pass away in our hospital. And the wife had a hard time. She herself, went back and forth to the hospital. Eventually, she ended up having terminal cancer. And we also had to go through the route of getting legal involved because there was nobody to make decisions for her. So it was very unfortunate, very unusual case. But again, dementia in an isolated way with no family is very difficult in these situations. So what's the future hold? Currently, right now, there's a lot of the health systems are really understanding that culture and language concordant care is important. So they are trying to promote that and making sure that we hire diverse team members, making sure that we have a team approach to care, especially in the geriatric or socially challenged patients. It's a team approach. Doctors, us as doctors, we can't do it alone. We will always try to be open and encouraging and try to elicit as much help as we can. And we have to be very open-minded to know that social issues and concerns really impact patients' care. And the care is beyond just the hospital. And so we need to promote that. So the pictures that are there, the picture on the side too, those are a lot of the community organizations that are doing a lot of work in API, but the pictures on the below, someone had mentioned before too that I do a lot of work in the health system on promoting culture networking for the physicians. So one on the top left is the East Asian physicians all getting together so they can network and know. I created a language referral guide so that way people can connect and know. If I am looking for a Mandarin speaking pulmonologist, we have a listserv of all the Mandarin speaking pulmonologists at Northwell. And anybody who speaks a dialect in or Taiwanese or Korean, all the different specialists so they can all connect with each other. So, and it's helpful not just on paper for us to meet, so that way we can see each other, because for physicians, I don't like to entrust care of my patient to someone I haven't really met before. So this is a great way to network and share and talk to each other. And some of them, they haven't seen each other for, I was like, oh, I always refer patients to you. I did. Thank you. Like, this is what you look like. I'm so happy you took such great care of my patient. I'm going to refer more patients to you. So that's how they exchange and network. And networking is important. Building relationships is important, even within the healthcare world. And on the bottom one, this is just recently, this is South Asian community physician. These are all the physicians there, and also very fantastic, very fun group. And they do amazing work, and a lot of them also involved in the community and giving back to the community. So it was really great fun. Now, even in the South Asian community, their languages are like, there's so many dialects and so many languages. So it was even more challenging to create the language referral guide, but we did it. And again, these are some of the languages. I had to pick the top 9 for the South Asian group. And we've already accomplished some. It says next to consider, but that was last year. We already did the Spanish referral guide, and now we're doing Greek. And then after that, we're going to do Russian. So, and again, creating more opportunities for physicians to know that these are the resources we have for our patients. On the bottom, it says Academy of Communication in Healthcare. So partnering with them in Northwell, we have all of our physicians and NPs and all the providers in the health system. We train them to have better communication styles and to be considerate of our patients and develop better ways to have more open-ended, more empathetic type of questioning and relationship building with our patients. And we keep in mind of our language and culture diversity as well. And not sure if you know, but there are healthcare systems across the country where they're trying to be as age-friendly as possible. Northwell, all of our practices are age-friendly, and our hospital has achieved the highest certification for age-friendly, where we implemented from our ED to our inpatient services and our outpatient practices. So this is something that we're very proud of, and a lot of the other health systems across the country have developed this as well. So that's something that's important because, again, we're in the aging revolution. I would be remiss if I didn't also share with you there is such thing as a guide program. This is not unique to Northwell. A lot of the other practices are out there. This is a Medicare benefit. But the guide program, what it pretty much does is to help caregivers really help the patients and the caregivers understand the disease process, and also review the home setting and make sure that everything's safe in the home. And they review and with the caregivers on other resources they can use to help provide as much resources for them as possible. It does require a visit either with telehealth or in person, and that's the phone number and the email to get qualified. It is covered under Medicare Part A and Part B. So it is helpful to know that they are restricted with insurances, but they're open to a lot of the New York City zip codes. So these are some of the key takeaways I would love to share. And that picture on the left is Dr. Thomas Lee. He's a Chinese American physician leader. He's the CMO of Press Ganey, and a really great leader. And he really talks about a lot on the patient experience and the physician experience, and they go hand in hand. And in order to really create better outcomes, especially in the experience of patients, we have to be as empathetic and culturally and language concordant as possible. So I really admire him, and this is what he promotes. And I love that there's an Asian physician leader at such a high position and a great organization as Press Ganey. And I don't know if you know what Press Ganey is. Press Ganey is responsible for understanding and surveying healthcare systems patients, not the staff, but the patients, on the care that they're receiving and how that their experience has been. And this is a great way for the health systems and the hospitals and the offices to understand how they can improve the experience of the patients better. It's not just the care, but the experience. And that's really important. We want them to feel like they're heard, they're being respected. So it's great that he's there leading the charge for that organization. So the takeaways are the API community is diverse. We want to avoid stereotypes and really understand that cultural humility is needed, not just cultural competency. Apply palliative care principles through a culturally responsive lens. Supporting the caregiver is really important. And the strategies to use is, again, open questions, involving the families appropriately, build that trust, and that using interpreters very effectively. Please consider using something like the video remote interpreter. And understanding that effective, transparent, honest communication is foundational to quality care. And advocacy matters. And the reason why we need to advocate now more than ever is because the challenges that Medicare and Medicaid faces, and it's really affecting some of the resources that's been already prevalent there that is underfunded. And now it's even more critical that we advocate because we are going to lose some of that. And we're hoping that we don't. And this is us at Capitol Hill with some of my mentors and the leaders in the geriatric and palliative service line in our health system, trying to advocate and work with the Congress on fighting for and save the budget cuts that are heading our way for Medicare and Medicaid.
Thank you so much, Dr. Park. I can't believe 90 minutes has gone so quickly with all of your rich experience and information. Thank you so much. We do have some questions in the chat, and we realize that some people may need to drop off. Some of the questions were, how do we get in touch with you? So thank you for putting your email up there. That's wonderful. Please feel free to capture that so you can reach out to Dr. Park directly. We will send out a survey, an email and a survey for those of you interested in CEUs or certificate of attendance. Please fill out the survey. We also ask that everyone fill out the survey. It's very helpful. The Hearst Foundations has given us a grant that helps support our professional development series, and we appreciate your feedback very much. So we do ask that you complete the survey, and we will send out a copy of the slides as a PDF with that email in the next couple of days. For those of you, do you have a moment to stay on, Dr. Park, for a couple of questions?
Yes, I didn't realize time was going so fast. I do talk a lot, so I try to be as
No,
quick as possible. I'm happy to answer any questions.
it was all great, and the case studies you shared were so illustrative and so helpful. So thank you for all of the wisdom and information you shared. So some of the questions were about how to reach you. I think there was a question about palliative care. I'm gonna take us off focus mode.
So yes, I'm looking at the question. There are some themes to them about palliative care services. Most of the bulk of palliative care services are provided in the hospitals. And in the ambulatory settings, there are pockets. There are home visiting geriatric palliative care programs, house calls programs, and there are good ones out there. Not all of them are palliative friendly, meaning they don't feel as comfortable with some of the palliative care services, but the ones that provide good geriatric care often have good palliative. So it is tricky to find, but it's there. But if you have any questions or concerns, please email me and I will try to share you as much resources as I can. Some of them are part of Northwell, some of them are not, because again, there's a lot of great resources out there, and sometimes you just have to ask the right questions or find the right people to find those resources.
Great. We also so much gratitude for you and for your passion and your wisdom. We do have a question here about the importance of DEI and provision of culturally and linguistically appropriate healthcare. And we're curious, are you concerned about the administration's attack on DEI initiatives and the effect of federal funding, including Medicaid and Medicare?
Yes, I am concerned. And a lot of the healthcare leaders are concerned. What a lot of the healthcare systems, some of them have been much more um, um, and it's interesting. There are things that, again, I don't want to talk badly about other health system, but at Northwell, not that we don't care about the executive decisions on or the administrative decisions on eliminating DEI, we still care about health equity. We still want to provide excellent care for our patients, and we're not going to stop. And that's something that comes from not only from our CEO, but all the healthcare leaders in our health system. So that is not going to stop. But we don't want to be targeted. So there's ways to talk about great care for all of our patients by making sure that we use the right terminology. And so that we can continue on with all the great work that we're continuing doing, and we're not going to stop. And like I said, the language referral guide is going to continue on expanding. The care that we provide and the equity that we are focused on is never going to end. If anything, I'm going to continue on applying for whatever I need to help fund the great work that we need to continue on doing. Now, Medicare and Medicaid, that is something we can't control as a health system, but what we can do is do advocacy and continue on helping those community organizations that are out there and continuing to partner as much as we can. I'm on the board of a nonprofit organization, and I'm going to do what I can and do my part to help them as well.
Thank you. And we have a question here, and then we'll get to you, Shira. But we have a question here from a Chinese-speaking social worker who's asking about any experience or situations with clashes in palliative care plans between different cultural medical modalities, especially between Western and Eastern medicine.
Yes, unfortunately, it's not just in the Chinese speaking community, it's also in the Korean speaking community and all the other API communities when there's clashes and delayed treatment. I had a patient that was an acupuncturist and did more Eastern medicine. And then unfortunately, it can definitely help supplement, but it can't replace some of the treatments that can be treatable. And my brother is an acupuncturist as well. So we both view that there's complementary, but one can't survive without the other, especially when dealing with such serious illnesses as heart failure or cancer. I've seen patients, come too late, stage 4 cancers, because they were using alternative methods. And again, I'm a big supporter of Eastern medicine, but we try not to judge. It's a choice that they made. But we try to be as open and accepting and empathetic as possible. Now, the other clashes about end of life or treatment plans, there are clashes. Palliative care is not often understood, which is why we have to explain that this is best care for the patient, where we look at quality of life. A lot of times, palliative care is often seen as hospice and stopping care. So I try to demystify or debunk a lot of the myths and untruths. So educating about palliative care, how it's complementary, and we always look at the patient's best interest and what's best for the patient. It's not about stopping treatment. It's also about clarifying treatment plans.
Hmm.
So it's yes, because people think of palliative because there's no definition or translation of palliative medicine in a lot of the other languages, but they do know hospice. So oftentimes it's misunderstood.
Yeah. Thank you so much. We have two hands raised, and thank you for those who are still here. We understand that people may need to go, and so if you do, please thank you for being here tonight. And again, there is a link to our survey in the chat, and you'll get an email as well. Shira. Hi.
Hi, everybody. Wow, that was a wonderful presentation. I feel like I learned a lot. I'm involved in Jewish outreach here at Caring Kind, so I appreciated the reference to the rabbis and the folks who are Asian and Jewish. Yes, that is true. I'm wondering a little bit about some of the myths that are out there and how you think we could go about debunking them. Like you said, I know that a lot of people are familiar with hospice, but less so with palliative, and this idea that there are in fact things that can be done from a from a palliative perspective when someone is in an earlier stage. So the examples you gave about like input into decision making was very helpful. But I know that there's still sort of a stigma that these services are out there maybe when someone's like stage 4 and has cancer and has a few days, and that's when they get access. And I don't know if that's being driven by the doctors and the providers who are kind of following Hippocratic oath and do no harm, or if there's something else that you think it gets in the way, but would really appreciate your insight on that.
So it's not just patients and families in the communities have misunderstanding. There's still physicians who don't understand how we can be helpful. So it is a lot of upstreaming some of the education. So we try to educate the residents and students earlier on that palliative medicine is here to help and not to be called at the last minute when you've done everything and thrown the kitchen sink and then you call palliative for help. So sometimes when it gets really hard and difficult, that's when they call us. As I call us before it gets hard. So that way it doesn't become to this crisis level, even for them, the medical team. So we try to really impart that with our medical team, our surgical team, our ED team. So it's a lot of education. So, yeah, they forget about us and thinking that, oh yeah, I guess I can call palliative. So we try to put triggers in, says, hey, anybody with stage 4 cancer, anybody with any type of dementia, think about this. We even have a scoring tool to help guide them. So there's different ways to help them. Don't forget about us. You can call us for help. But again, there's not enough of palliative care staff too. So, sometimes we can't handle the volume of consults. So that's the other thing too. But, in our hospital, we try to take care of them as early as we can. Or we also do education to the medical team. You can do primary palliative. You don't have to always wait for the specialist to have these conversations and to impart palliative care services and needs. And again, it's not just a physician, it's really involving social work too. Yeah, social work is a key part in all of this. I can't do anything without our social workers who are part of our team.
Thank you so much. Linda, hi.
Hi there. You partially answered my question already, but this is my mom. She's going to be 93 this year. She was diagnosed with Alzheimer's dementia in 2021. We've been living together for the past 5 years and 3 months. I was a New Yorker for 18 years prior to that, but these past years we've been living together, and we're at the moment down in South Florida. Her primary, who's also my primary, just doesn't quite understand palliative. We've talked to him. She's very clear that she wants, if she does not want to have any hospitalizations or surgeries. So in the event of a hip break, she would not want to have surgery. We've talked to several special doctors, and they say that the general anesthesia will just make the dementia worse. So if there's a clash between what she wants, or what she has expressed that she's wanted over all these years, and what I know to be true, and what the doctor may want her to do in the moment, what do we do then?
So it's interesting. I mean, no one's going to say, oh, great, you don't want surgery for hip fracture because actually I'm a big proponent of fixing hip fractures because uh, nowadays we can do anesthesia in a much safer way, and we could do injections and spinal injections for anesthesia. So that way she doesn't have to go through general anesthesia. Now, every patient is different. She has to be evaluated, but hip fractures also can be painful, and we don't want our loved ones to be in pain, and it cause more mobility issues that can make the dementia get worse. So there are programs out there, and especially in our hospital, we try to get a patient into the OR within 24 to 36 hours. So that way the morbidity or mortality reduces drastically. So I'm actually a proponent of fixing hip fractures if possible. If she's already bedbound, that's a different story. But if
No.
she's already mobile and can walk around, we want to maintain that mobility as much as we can to enhance quality of life. But if she really still insists on not doing surgery, you don't have to call 911. You can also look into a home visiting doctor program or house calls program too, and seek out outpatient palliative or a geriatrician if you feel that your physician is not a great advocate for your mother and providing the right care. Not to say that lose him, but there are resources out there that could be supplemental. You don't have to lose your PCP. You can find a geriatrician and still keep your PCP. You can find a palliative care physician or geri-pal physician and can still keep your PCP.
Okay, and then maybe then based on what you're saying, I should try to find a hip surgeon who knows
Yeah.
who knows how to orthopedist who knows how to do the kind of surgery you're talking about. Although I will say
geriatric or comfortable in geriatric hip repair that is open to different types of anesthesia or very mindful that she's at risk of delirium. Not all anesthesia is bad, but depends on it depends on every scenario.
Okay, great. Thank you.
Thank you so much. Again, a lot of gratitude in the chat. Thank you so much for being with us, Dr. Park.
Thank you. And thank you for allowing my dog to be part of the presentation. I'm really sorry.
Oh, no problem at all. Thank you everyone for being with us tonight. We do have the survey, the link to the survey, and an email will follow, and we encourage you to stay a part of our community. Our goal is to be trusted partners with you, with professionals, with people living with dementia and their families. So please stay in touch with us, come to our education programs, call one of our amazing navigators who can help with specific issues. We are here for you and your community. And again, Dr. Park, give you just the biggest round of applause and gratitude. Thank you so much.
Thank you all. Have a great evening.
Thank you, everyone. Have a good night.